Hello, here what you're seeing is a question paper of MBBS first professional exam for the students admitted in 2019. This question paper is from JNMC, that is JN Medical Jawaharlal Nehru Medical College, AMU Aligarh Muslim University, Aligarh UP. So this question paper, this exam was conducted on 5th of February 2021. And here you're seeing that this examination is of an human anatomy paper 1. And this was of 100 marks and in 3 hours duration. This was section B and section C. Both of them were subjective. Then down below you're seeing is section A. Now this section A, here you're saying they have like 20 MCQs, right? And each one of 1 marks, that makes it 20 marks section A. So here I'm going to solve these 20 MCQs one by one. This will help you to learn and understand, and those who have attempted, they can check the answers, and for the future students, they can learn from this. So question number 1 is, to assess the movement of supination and pronation, the elbow should be flexed at 90 degrees, elbow should be fully extended, shoulder joint should be flexed at 90 degrees, shoulder joint should be adducted at 90 degrees. So now look here, this is what I'm drawing is, let's say I'm drawing is of a flexed hand of, let's say we're drawing it of right hand supinated position, hand. So when this is a right hand at flexed elbow, if your palm faces above, now this is called supination. This is supination. Now in this position, if you bring this, if you rotate this medially, so what will happen now, this is called pronation. In pronation, what will happen, your dorsum of hand will face above, like that is like a giving tip top of position, and this supination is like a begging stick when your palm faces above, right? And if you repeat that again after, like, being supination, and if you bring it back now like this, now this will again be called supination. That is lateral rotation. From a pronated hand, if you rotate it laterally, it again becomes supinated hand. Now why are we doing it this in a 90 degrees? 90 degrees. So remember, there are two pronators. When you're talking about pronators, there are two pronators and two supinators. So, the proximal, the proximal one pronator is pronator teres. Pronator teres. While the distal pronator is pronator quadratus. Pronator quadratus. Similarly, now supinators. The first one I should write here is biceps brachii. Biceps brachii. And the second one is supinator muscle itself. Supinator muscle. So now talking about supination in an extended elbow. So when you're doing supination in an extended elbow, remember that supinator causes, it's more involved in extended elbow. This is more involved in extended elbow. While we talk about pronation in an extended elbow, because pronator quadratus. Now this is distally placed, right? So in an extended elbow, the muscle which is more involved is pronator quadratus. So pronator quadratus pronates the forearm in an extended elbow. But what happens in a flexed elbow? Now, because when we flex the elbow, actually the rotation of humerus is restricted. So when humerus rotation gets restricted, remember there were two heads of pronator teres, a humeral head arising from the medial supracondylar ridge, and there was another head of pronator teres arising from the ulna, upper end of ulna medially. So the two heads of pronator, the humeral head comes into play when you are, when you are flexing the elbow. So pronator teres causes pronation in a flexed elbow, right? Now, similarly, remember the chief supinator of forearm in a flexed elbow is biceps brachii. So this muscle is chief supinator in a flexed elbow. Got it? Now, why? Because these two muscles are taking origin from above to the elbow joint. So, to to bring about the actions more precisely, humerus needs to be fixed, and that is done by flexing the elbow. So, to assess pronation, because that superior radioulnar joint. Remember this also. Superior radioulnar joint is what type of joint? It is a pivotal variety of synovial joint. So that's why you always, when you have to, assess for supination and pronation, we flex the elbow at 90 degrees so that the rotation of humerus gets restricted. So here the answer will be that to assess the movement of supination and pronation, elbow should be flexed at 90 degrees. Remember, there are so many points, they're all important for your MCQs further. Now the next question is question number 2. Wrinkle lines of the body are determined by. Remember what they've written is wrinkle lines of the body. They're determined by pattern of fibers in the dermis, thickness of dermis, thickness of epidermis, thickness of keratin layer. So this question, actually, I would say that this is not properly framed, because wrinkles. Let's talk about wrinkles. Now wrinkles in the skin are different types. Let's say first of all we're talking about the congenital wrinkles, or since birth. Since birth there are some folds. Since birth there are folds in the skin. If you see a newborn, there will be like flexion creases. Flexion creases. You must have seen those flexion creases in an in infant, like they're in the front of the neck, elbow, ventral surface on the anterior surface of the elbow. Their flexion creases the wrist at the ankle. So those flexion creases, actually they are congenital, and those are because of the foldings, to permit the movement. So these are congenital. Congenital, or as you can say, they are genetically determined. Okay, then this was about the flexion creases. Then about other types of wrinkles, let's say because of pregnancy, post-pregnancy, post-pregnancy. Because of the stretching, the skin, that gets stretched during the pregnancy, then after, postpartum period, there'll be shrinking of the skin, है ना? So that shrinking actually, now these folds actually, the, striae gravidarum, you must have heard. Those streaks are actually because, the skin splits there at those, stretching, so that marks the whitish lines that's called stria gravidarum. And similarly, if you remember, there was like if your person gets obese suddenly, or even due to heavy, like doing exercise, strenuous exercise, also sometimes, on like thighs and all, gluteal region, or even the arms. So you find the streaks on the skin. Actually, they are like called stria albicans. Now, these are all because the splitting of fibers of the dermis. Then, sorry, then what about like sunburns? Sunburns, what happens in sunburns? The sunburn also in a first degree, second degree, and all. If they're a periodic, occasional sun bathing, there will be, tanning of the skin, and that is actually, you know, um, because of uh, the top layers of the epidermis that gets burned out. So there will be very fine wrinkles due to sunburn first degree, but due to second degree is like, people who have a regular habit of taking sun bath. So in them, what happens is even the dermis gets thinned out, and tanning and the wrinkles brought is about because of the thinness of epidermis initially, and then the thinness of the dermis, right? Then there are what else type of course I know that, I mean, this is by default they must have asked is about the aging wrinkles. Now, aging wrinkles aging wrinkles is that is due to age. So let me tell you that the aging wrinkles actually start from 25 years onwards. And this 25 years onwards, what happens is that the dermis. Let's talk about the dermis. The dermis is two layers. You have a top layer called the papillary dermis, remember, and like this is the epidermis. You have this is the dermoepidermal junction. You have the dermis. Now this is the papillary dermis. This is the papillary dermis, and this one here you have, this is made up of a reticular pattern of collagen fibers, and mixed with them will be the elastic fibers, right? So this because of this mixed pattern of elastic and reticular fibers, this is called reticular dermis, and collagen is of various types, type 1, type 2 to type 10 and all. So but this uh, that's why it's called reticular dermis. Remember, the reticular dermis is classified as dense, irregular, irregular fibrous connective tissue, and that is the very reason that it makes the skin very tense, and skin very very strong substance which is used as a leather, that makes it the quality of this property of skin is actually utilized as a leather. But there are some, you must have heard about Langer's lines. Now, Langer's lines, let's talk about the Langes lines. Langes lines. Langes lines, you must have seen the body that has like different portion in the body, and there you must have seen in the books that they mention that there are different types of pattern of fibers. That's how the fibers are distributed in the body, in the dermis. That is why they say these Langes lines are actually of cosmetic importance, or you can say surgical importance. Giving an incision along the Langes lines will be a cosmetic incision because that will, heal easily, leaving less of or minimal of scarring. But if you give an incision which is at opposite or 90 degrees or cutting those lines of Langes, there will be more of scarring, and even there will be a gaping of tissues, and there will be more of scar produced after healing. So it is always preferred that during surgeries we give an incision along the lines of Langes. Now you should think, when we have already talked about that the dermis is having dense irregular pattern of collagen fibers, and at the same time we also are saying and we're learning that Langes lines is a peculiar pattern of collagen fibers. So what to accept? So remember now, for this, that no doubts, like this is of course true, very true, that we use the dermis for leather, uh, you know belts, leather, wallets, purses, and all, because of the strength of this dermis being irregular fibrous connective tissue. But parallel arrangement of collagen fibers is not seen. If you see the histological slide of a skin, you will not find that the dermal fibers are parallelly arranged. But it's instead that we should accept this also. So remember that there are some layers of collagen fibers in the dermis. They're also parallelly arranged, right? So both of these facts you should have to accept, and you should learn that most of the dermal fibers, the collagen fibers, they are irregularly, haphazardly reticulate, a dense meshwork of collagen fibers in the dermis, and that's why you call it as a reticular dermis. But there another fact is also you have to learn that they're parallelly arranged fibers, and that you know is of surgical importance. So we're back to topic. We're talking about the wrinkle lines of the body, and before I skip, I just am reminded of one more type of wrinkles, and that is the wrinkles of the facial expression, right? So here I'm going to write, there's less of space, so let's continue with number 5. The other type of wrinkles are due to uh, facial expression. Now this is another type of wrinkles. So you must have seen, even as I was saying, that beyond 25 years you will find the wrinkles, those are because of aging. And of course, with age, these wrinkles, they become more marked. But facial expression wrinkles you can find right from the childhood. And the wrinkles due to facial expression are because of subcutaneous muscles. So remember that because there are subcutaneous muscles in the face, and remember scrotum, the wrinkles in the scrotum, they again are because of the subcutaneous muscle, the dartus. So remember the expressions, these wrinkles can be because of so many reasons. Maybe because of, subcutaneous muscles, maybe because of the sun bath, maybe because of the pregnancy or heavy exercises or obesity, or maybe the flexion increases since birth. But by default, when you talk about wrinkles, everybody comes to this conclusion that we're talking is about aging. So aging, the answer, like we're back to here, we are concluding with this, closing up with this question. So the pattern of fibers in the dermis, remember this is actually of surgical importance, right? And the wrinkles do not happen in the pattern of the fibers in the dermis, that is for surgical incisions. So what I have learned, and I'm going to tell you that in case if this question gets repeated, the answer will be thickness of dermis. So the answer will be thickness of dermis. And 2B will be the answer. Because with aging, actually, not only there will be, degeneration or thinning of the elastic and collagen fibers, also the thickness of the dermis keeps thinning out. So with the thinning of the dermis, the skin gradually keeps folding and find initially they find wrinkles and then they become really very important, right? So that was about the thickness of dermis. And nasolabial fold, what will you say nasolabial fold about? Now nasolabial fold again is a part of facial expression, but that also those facial expressions, like let's say the horizontal fold creases on the forehead, they're a part of facial expression, but they will become more prominent and they will become more persistent with aging. So there is overriding of two things. One is that the facial expressions are because of subcutaneous muscles and also because of aging, like nasolabial folds also. Initially, they are because of the subcutaneous muscles, but with aging, they will become permanent. And now the reason will be because of the thinness of the dermis. Question number 3. Intervertebral joint is an example of primary cartilaginous joint, secondary cartilaginous joint, then you have fibrous joint and syndesmosis. Again, I will say that this question is not properly framed. Intervertebral joint, actually, when you place vertebrae one above the other, remember there are pedicles, then there are transverse process, and then you have a spines process like this, right? And here you have is the vertebral foramen. Similarly, will be the case here also. This is the transverse process, this is the spinous process. Now, remember that when two vertebrae are placed one above the another, they also have these, sorry, I think when these vertebrae are placed one above the another, from, a vertebrae above and a vertebrae below, there are joints formed like this, right? The joints formed. This is called the inferior articular process from a vertebrae above, and this is the superior articular process from a vertebrae below, right? So this is again, and this you are seeing what I have marked is also an intervertebral joint. This also is an intervertebral joint, and these joints are called zygo zygopophyseal. These are called zygopophyseal joints, and they are paired, and they are plain synovial joints, right? So they are paired. That means two joints I've already told you. Now the one they, I presume what they have are there, and you also must have guessed what they've asked is this joint that is between the body of vertebrae. So in the body of vertebrae, you have this fibrous, this is an intra-articular, or you can say not rather intra-articular because that word is for synovial joints. Here you can say that is, intervertebral fibrous disc placed between but at the same time, these surfaces will be lined by hyaline cartilage. That is a feature of secondary cartilaginous joint. When the two surfaces of the bone, they participate to form a secondary cartilaginous joint. First of all, remember the one feature is that they will be lined by hyaline cartilage. So the articular surfaces covered by articular cartilage is a feature of secondary cartilaginous as well as of synovial joints. But here in between, they have a fibrocartilaginous disc placed. So this joint now, uh, this joint is called, sorry, this joint is called intervertebral joint. But this will be said as intervertebral joints between body of vertebrae, right? So now, how many joints you have concluded? That in intervertebral joints are actually three joints. There are three joints. So I would say that this again, right? This was not a well-framed question, and even this is not a well-framed question because intervertebral joints are actually three in number. But luckily, there is no option as plain synovial joint here, right? So they have, like, you can say that you'll ultimately have to come to this joint that is between the body of vertebrae, because there is no option as plain synovial joints. So your answer will be secondary cartilaginous joints. Next question now is about following statements do not relate to compact bone. Lamellae are made up of collagen fibers. Osteocytes are present between the lamellae. Lamellae with Hawaiian canal constitute an osteon. Volkmann's canal are placed parallel to the medullary cavity. So which one is not the correct statement? I think following statements do not relate. Right. So to find out the wrong statement, so let's see a fast diagram here. You are seeing is a cortical bone, right? Cortical bone has many names. Cortical bone is also called lamellar bone, or it is also called as dense bone, right? Or it is also called as Hawaiian bone. All these are name of the same type of bone. The other bone which is present in epiphysis and the ends of the bones, that's called spongy bone, trabecular bone, cancellous bone, right? So that these are different words. You should remember that all these four terms, they're related to the same bone. Now cortical bones are actually present, we are talking is about the diaphysis of long bones. So on the inner side you have a concentric layer of lamell, I don't want to go in detail. There'll be like, lacunae filled with osteocytes, then there will be dendritic, as protoplasmic extensions communicating with the adjacent, and also there will be a peripheral layer. And now in between, like let's say we are talking is about a cut section of a long bone. So what else you will find here? There will be, you know, there's a nutritional foramen that enters into the long bone. And remember that nutritional foramen are oblique foramen. Nutritional foramens have a direction. So this you are seeing is the direction of the nutritional foramen. So that is an obliquely directed. We say now the growing end of the long bone is opposite to the direction of the nutritional foramen. That means nutritional foramen is not a transverse foramen. It is directed to either of the two ends of the long bone. So that means it's an oblique foramen. Now, there you'll find is the openings of these vertically running canals. Now, these vertically running canals, here also you might find that there's a vertically running canal, and there will be like communicating canals, which are oblique canals. So these are called Hawaiian canals, Hawaiian canal, and these obliquely running canals are called, sorry, these are called Workman's canal. ठीक? So Workman's canal are oblique, oblique running canals communicating between the vertically running Hawaiian canals. These are vertical canals, right? And of course, there will be lamellar arrangement, there will be concentric lamellar arrangement around to these vertically running Hawaiian canals, and that is what they have said. They are called osteons, lamellae with these are the lamellar arrangement of the osteocytes. So the lamellae along with the Hawaiian canal, they constitute the osteons. And these lamellae are made up of lamellae are the concentric and the peripheral and concentric rings. They're formed by these collagen. Remember, collagen type 1. Collagen type 1. This might again be a question sometime. So, what type of collagen you find in a bone is collagen type 1. They form the lamellae of the compact bone. Look here, I should mention this also. Compact bone. So many names for this diaphyseal portion of the long bone. I hope you've got the answer now that following reasons do not relate. So, what does not relate to the compact bone will be Volkmann's canals are placed parallel to the medullary cavity. Elastic cartilage is present in costal cartilage, thyroid cartilage, tracheal rings, ear pinna. For this, you need to remember the examples of elastic cartilage. So let's revise this now. Examples of elastic cartilage. So number one, if everybody knows here, the answer will be ear pinna is one example. Then you have epiglottis. Then you have cuneiform. These are the paired cartilages of the larynx. Then you have corniculate. These also are the paired cartilages of the no. This also is paired cartilage of the larynx. And then you have tips. Remember tips, or rather I should write it as apex. Apex of arytenoid cartilage. Thick. This also. So these are the examples of elastic cartilage. Remember them. And I hope you got the answer now for this. Answer will be ear pinna.
Question number 6. Wall of the large artery mainly consists of collagen fibers, elastic fibers, smooth muscles, reticular fibers. So let's be fast here. Now you're seeing is a lumen of a large artery. Then you are seeing is the next layer, that's tunica media of a large artery, and outside will be the third layer. Now this is a pattern seen in all the vessels, not only the arteries but also in veins and lymphatics. They are all made up of three layers. So now we're talking about the inner layer, that is tunica intima. and this is made up of simple squamous cells, and that's called endothelium, right? So here you find is simple squamous cells, right, the endothelium. Then this middle layer, the middle layer has two components. Now this middle layer is having a lot of elastic fibers. Elastic fibers are filled in the large vessels, the large arteries. This is elastic fibers, although you will also find some smooth muscles interpreted in between this, but the smooth muscle content will be less here in the large arteries. This is smooth muscles, and this layer we're talking is about, that's called tunica media. Okay, then the third layer, the outer layer, as I already told you, is tunica adventitia. Now this is the fibrous layer. Okay, but remember, when the arteries are itself very thick wall, let's say, like, the large arteries, they do have a vessel for itself also, and that arteries runs over to this, in you know tunica adventitia, and they supply blood to the inner layers. Now such an artery which supplies blood to the large artery is called vasa vasorum. This is called vasa vasorum, right? Okay, and the best example of vasa vasorum, if anybody asks, like, what is the best answer example of vasa vasorum, then it will be, remember, coronary artery is the best example of, you know because the human circulatory system is a closed circulatory system, so heart is a part of the vasculature, and it's really very thick. So to supply blood to the vasculature, to the musculature of the heart, you have vessels coming out from the vessels and supplying the wall of the heart. So coronary artery is the best example of vasa vasorum. Now, unlike to these large arteries, remember, large arteries, one important thing is that you have a smooth inner lining, that is tunica intima, and the endothelium is a smooth lining because of the elastic recoil of these. Now, what you're seeing here are the, what I have drawn is the large arteries. These are large arteries. Now, in case of medium size artery, well, I'm not drawing here, medium size artery will happen here, that instead of these elastic fibers, you have more amount of smooth muscles in tunica media, as well as because of this, contour of this muscles of this tunica media, it's smooth muscles in medium size artery. Medium size artery, what will happen here, that the inner lining, the tunica intima, will be like this, corrugated. Then you'll have is the tunica media, and then you have is the adventitia on outside. So one important another feature of smooth, one thing is it will be filled with the smooth muscle fibers. This is medium size artery, as well as the tunica intima, the endothelium will be corrugated because of the muscular wall, tunica media. Then that's why this medium size artery is also called the muscular artery, and elastic arteries are also called large arteries also called as elastic arteries. Now, in case if they're sometimes it's a good question, they might ask you in a graph format. Let's say on the x-axis you're showing is the size of an artery, and here on the y-axis you're showing is the content of smooth muscle and elastic fibers in tunica media, right? And the graph is shown to be like this. So what will be this graph showing, the smooth muscle or the elastic fibers? Now you can confirm, because as the size of the artery, elastic fibers will increase as the size or the caliber of the artery increases. And at the same time, if they show a graph like this, what will this represent? Remember, this will be the smooth muscles. So as the size of the artery increases, the content of smooth muscles in tunica media decreases, and as it increases, the size of the artery decreases, the content of smooth muscle increases. But this will be limited here between the small, and then you have medium size artery, then you have is the large arteries. I hope you well understood about this. So the answer now about this question here, that the wall of the large artery mainly contains elastic fibers, will be the answer here, right? Question number 7. Tendon just medial to the Lister's tubercle of radius is extensor carpi radialis longus, extensor digitorum, extensor pollicis longus, abductor pollicis longus. So, tubercle of Lister, I think you would understand this while I'm drawing here, is, let's say, the dorsal aspect of radius. So if this is the dorsal aspect of radius, the stelloid process here, here you find is the dorsal tubercle of Lister, and there will be a groove here like this. And here, of course, will be the ulnar stelloid process. And one important thing here is this, because I have come across this point, let me tell you that the radial stelloid process, and if you talk about the ulnar stelloid process, this is around 1 centimeter. 1 centimeter distal. So the radial stelloid process is 1 centimeter distal to the ulnar stelloid process. If you're seeing this is the dorsal aspect of the right wrist, right? So the tendons we're talking about, remember, through this first space, there'll be two tendons that pass. And these two tendons are actually, this one, let's say, is coming from ulna. So which tendon comes from ulna? Sorry. Let's be fast. The two bones, and there you have an interosseous membrane in between. A muscle that from dorsal aspect of radius crosses this first space. Now this, if you talk about, there are two, let's say there are two external, I think I should use the red color, that will be better. There's two muscles that arises from the back of radius and back of ulna. So this muscle arising from the dorsal aspect of radius crosses this extensor retinaculum to the first compartment, and the other one crosses this extensor retinaculum through the third compartment, and both are extensors of the thumb. So think about which will be extensor pollicis longus and extensor pollicis brevis. So very easy to remember now. The bone which is closer to the thumb will provide origin to the shorter muscle, the smaller muscle. And ulna, being away from the thumb, will provide origin to the muscle that is long. So this will be extensor pollicis brevis, and this will be extensor pollicis longus. Then there is another muscle that takes origin from both the bones. Both the bones means that takes origin from both radius and ulna as well as the interosseous membrane, and this muscle also accompanies this extensor pollicis brevis and emerges from the first compartment. So this muscle here, again the second muscle here, there are two muscles coming out from the first compartment. So this muscle will be abductor pollicis longus. because there's abductor pollicis brevis is a part of thenar group of muscles. That's an intrinsic muscles. So now you've seen here that this is space formed here is what is called as, what is this called? Anatomical snuff box, right? There's the anterior boundary. Remember these two muscles, they form the anterior boundary of anatomical snuff box, and extensor pollicis longus forms the posterior boundary of anatomical snuff box. Then the floor, their second compartment, remember there were two extensor carpi radialis longus and extensor carpi radialis brevis coming from the later supracondylar ridge of the humerus. So they will become, these two muscles, they will become, two muscles passing to the second compartment, they will be forming, passing to the floor of the anatomical snuff box. Now focusing upon this black color thing here, this black color thing is what has been asked in question, and this is called dorsal tubercle of Lister. So it lies between the second and third compartment below the extensor retinaculum. Don't forget that here there will be an extensor retinaculum. An extensor retinaculum is an oblique retinaculum. Unlike the flexor retinaculum on the palmar surface, that is a transverse retinaculum. Okay, so this retinaculum provides actually a hinge, right? So this extensor pollicis longus, while reaching into the thumb, it actually hinges along to this dorsal tubercle of Lister. The advantage that you get because of this fulcrum effect, that you can easily, if you try to extend the thumb like with a jerk, you will find that the jerky extension of the thumb is because of this extensor pollicis longus, and this dorsal tubercle of Lister is helping you there. So, and also remember when we talk about the terminology of position, so we always give this medial and lateral terminology not according to the position of hand, rather according to the anatomical position. So this being the lateral bone and this being the medial bone. So now repeat the question. Tendon of which muscle? Tendon just medial to the Lister tubercle, right? So they have asked tendon just medial to the Lister's tubercle. What will be the answer now? Extensor pollicis longus. Now the next question number 8. Question number 8 is extensor compartment muscle that causing flexion of the elbow is anconeus supinator brachioradialis extensor indicis. Look, what are the muscles? Like there are superficial and the deep muscles in the back of forearm, out of which those which pass below the retinaculum, right? So those which pass below the retinaculum, between the first compartment below to the first compartment was, I just told you, abductor pollicis longus, extensor pollicis brevis. Then for the second compartment, what was passing below was extensor carpi radialis longus, extensor carpi radialis brevis. To the third compartment, what was passing was extensor pollicis longus. To the fourth compartment, what was passing? Extensor digitorum, extensor indicis. And you have what? Very important point. You find will be posterior, no, or interosseous artery. Which artery? This is very important. Not posterior, but anterior interosseous artery, because it perforates the interosseous membrane from the anterior aspect and reaches into the back of forearm in the lower one third of the forearm. So it will be anterior interosseous artery. It's a very important point. And then you have posterior interosseous nerve. These four structures will pass below the extensor retinal fourth compartment. Now the fifth compartment will be for extensor DGT minimi. Then sixth compartment for extensor carpi alaris. So these are all the extensors, the wrist or the back of in the back of forearm. But in the extensor compartment, there are other muscles like supinator is one, and one other muscle is brachioradialis, right? But supinator is just for supination because it's applied by radial nerve. It also is considered to be the back muscle or deep muscle of back of forearm. But brachioradialis muscle, remember, it is lateral throughout, it extends, right? Brachioradialis we are talking is that brachioradialis actually arises from the lateral supracondylar ridge of humerus, right? And it descends down and reaches and gets inserted onto to the lateral aspect of the styloid process of the radius. And remember that brachioradialis, if you remove and reflect brachioradialis, what you will find below? Yeah, they will find is the radial artery accompanied by the the lateral artery and the superficial branch of the radial nerve. So brachioradialis doesn't passes through the extensor retinaculum. And remember that brachioradialis being laterally placed in the forearm, it also is comparable. It is compared to which muscle of the leg? Rather, it's compared to the lateral compartment of the leg. You have proeminence, peroneus, brevis, peroneus longus in the leg. So in the forearm, if you compare the homology, this brachioradialis actually represents the lateral compartment of the forearm, but we consider it the muscles of the back of forearm, right? So a muscle of the extensor compartment. So I mean, when you talk about action of brachioradialis, it actually it brings your hand in from supination to pronation, from pronation to mid prone position. This is the position. Like if your palm is facing like this, it will bring it into mid prone position. And if your palm is facing like this, pronated, then also it brings it in mid prone position. So mid prone or mid position of supine or mid supine. So it brings your hand in this position, and that's why it is also called as hand shaking muscle. Got it? So the answer here, extensor compartment muscle causing flexion at the elbow, right? Because it is arising from above the elbow. This is the only muscle. I mean, this is arising from above the elbow. So this will cause flexion at the elbow, right? And apart from this action, there will be also flexion at elbow. So these are the actions of brachioradialis, flexion at elbow, and in which position? In mid prone position of the forearm, right? And that's why it's called a handshaking muscle. So the answer to this extensor compartment muscle will be brachioradialis. Now the next question is question number 9. One of the rotator cuff muscles not responsible for rotation of the humerus. You have supraspinatus, infraspinatus, subscapularis, interis minor. So just see this diagram here. I've shown you is the head of humerus in a transverse cut section, and here you're seeing is the glenoid fossa. And here on humerus you have is the anterior tuberosity, and here you have is the lesser tubercle in front, and here you have is the greater tubercle placed laterally. This you are seeing is the right shoulder joint in a transverse section. So which muscle attaches here? This will be to the lesser tubercle. This will be subscapularis, right? Then here there are 3 muscles attached to the greater tubercle of humerus. 1, 2, and 3 muscles. And this is SIT. So this one is supraspinatus, and this is infraspinatus, this is teres minor. All these they have already mentioned. These are the four muscles of the rotator cuff. Supraspinatus, now remember that this causes medial rotation of the, helps in medial rotation of the arm at the shoulder joint. Similarly, teres minor and infraspinatus being arising from the dorsal aspect of the scapula, they will cause lateral rotation of the humerus or the arm or the at the shoulder joint. Supraspinatus, while it's coming from above this, spine, that is supraspinous fossa. Now, supraspinatus actually causes, it pulls this, humerus like this. So, this actually causes abduction, right? Initiation of abduction for initial 15 degrees. And these two muscles cause lateral rotation, teres minor and infraspinatus, and this subscapularis causes medial rotation. Question number 10. During ovulation, the secondary oocyte remains at what specific stage of meiosis? We are talking is about the secondary oocyte. So now remember, when we talk about primary, and the answer choices are prophase of first meiosis 1, prophase of meiosis 2, metaphase of meiosis 2, metaphase of meiosis 1. So let's talk about first about primary oocyte, and then we'll talk about secondary oocyte. Right? So primary oocyte undergoes, this primary oocyte is arrested until puberty. This is arrested in prophase of meiosis first. If precisely asked, like prophase, which stage of prophase, now that will be diplotene. So the primary oocyte just before, now this is another important point. When do they undergo its first meiotic division, that is the reduction division, and this changes into secondary oocyte. This is called the first meiotic or reduction division. Remember, this happens just before ovulation, right? So the daughters, this is 2n in number, this will be haploid in number. That is secondary oocyte, that is the gamete. Now there will be a polar body and a secondary oocyte formed. Now this secondary oocyte will again get arrested, and this secondary oocyte gets arrested in metaphase of meiosis 2 until it gets, this again another phase, because it will complete its second meiotic division. Now this will happen here just at the time of fertilization. The male gamete enters into the ovum, and that's how that's the time where the secondary meiotic division will complete, and the second polar body will be extruded out into the prevituline space. So these are all the important points I have mentioned here. This will help you further. So the answer to this, during evolution, the secondary oocyte remains in what specific stage of meiosis? So this is secondary oocyte, then the answer will be metaphase of meiosis 2. The next question now, question number 11. Which of the following structure prevents implantation of a blastocyst? Secretory phase of endometrium, zona pellucida, corona radiata thicca interna. So answer is zona pellucida, of course. But let's revise some important points about zona pellucida. The advantages we get from zona pellucida: one, you know it that it prevents implantation. So right from the graphene follicle stage, remember it develops before ovulation, right from the graphene follicle, then then fertilization, then you have zygote, then the cleavage, then you have morula, then blastula, the mulberry stage, then you have the blastocyst. Now the blastocyst is the stage which has to get implanted in the embryo. Now that until right from this graphene follicle up till blastocyst stage, zona pellucida is present there. So when zona pellucida gets disappeared or it gets dissolved, that is the time when blastocyst gets implanted. So it prevents implantation of zygote, or like the embryo, let's say embryo at abnormal site. One important function is this. Second function is it prevents polyspermy. Means it allows entry of only one sperm head to enter the ovum, and right after that there is a zonal reaction and it prevents further sperm heads to enter the ovum. Third important point is that it prevents not a single sperm to enter from a, different species. So it prevents not a single sperm, or it, you can say in another words that it prevents fertilization from a different species, from a sperm of different species, right? So it prevents implantation from a sperm of different species, prevents giving out to different type of offsprings. Then last of all, it prevents immunological reaction, right, against the sperms and the new embryo being formed. So these are the important functions of zona pellucida. So you got it now. The implantation, which of the following structure prevents implantation? Answer will be zona pellucida. Now question number 12. In a developing embryo, chorion is derived from ectoderm, parietal, extraembryonic mesoderm, syncytial trophoblast, cytotrophoblast. So let's have a fast revision here. We are talking is about the stage, when there are trilaminar disc that is formed. So the trilaminar disc, let's say you have the three layers being formed here, like the innermost here down below is endoderm. This is endoderm. Then the middle one is the mesoderm, and towards the animal pole there is the ectoderm. So what happens is there is an amniotic, the antral cavity being formed here, right? And this is the developing embryo, and here you have is the yolk sac. This is the yolk sac. All this surrounding is this is extraembryonic mesoderm. This extraembryonic mesoderm later gets splitted. Later gets splitted. So what you're seeing here, that this gets splitted like this. I mean, yes. So this gets splitted like this, and there is a coelom created. There's a coelomic cavity created. And after this creation of coelomic cavity, remember now this yolk sac is called secondary yolk sac. Earlier it was a primary yolk sac. After the formation of this splitting of extraembryonic mesoderm, this is extraembryonic mesoderm. So now what happens, it gets divided into this layer called parietal layer of somatopleuric mesoderm, right? This is a parietal layer of extraembryonic mesoderm, or you can say somatopleuric mesoderm. And the layer of extraembryonic mesoderm adjacent to the embryo now will be called, the visceral layer or splanchnopleuric layer of extraembryonic mesoderm. Okay. Okay. Now, this all what is being developed is actually from outside is formed, there's a layer of cells which was forming this extraembryonic mesoderm as well. Now, this layer from outside is a layer of trophocytes, trophoblasts rather, layer of trophoblasts. This layer now, I mean, this layer in future now will be called chorion, right? So chorion actually is made up of, remember now, parietal extraembryonic mesoderm, or sometimes they may write it as somatopleuric extraembryonic mesoderm, right? Extraembryonic mesoderm. Plus, don't forget the blue thing, plus the layer of trophoblasts. These trophoblasts later on will form inner layer of cytotrophoblasts and an outer layer nucleated, multinucleated pool of nuclei. Remember, it's a syncytium. That's why it's called syncytiotrophoblasts. Right? So this is, finally what is called chorion. So remember, chorion is formed by this. So answer to question number 12 is that the developing embryo chorion is derived from parietal extraembryonic mesoderm. Although this option is incomplete, they should have included a layer of trophoblasts as well as plus trophoblast. Okay, so this question would have been better framed. Question number 13. Injury to the following cranial nerve will result in defective movement of the eyeball. Optic nerve, abducent nerve, trigeminal nerve, facial nerve. When they're talking about defective movement of the eyeball, so the movement of eyeball is controlled by 6 muscles. These are extraocular muscles, and you know that out of these 6 extraocular muscles, 4 muscles are innervated by oculomotor nerve. oculomotor nerve, that is third cranial nerve, and these muscles are superior rectus, inferior rectus, medial rectus, inferior oblique. Plus, in addition, it also supplies plus LPS, levator palpebrae superioris. Lateral rectus is supplied by abducent nerve, right? LR6, while superior obliques is supplied by trochlear nerve, SO4. Right, so it was a very easy question. I mean, you can easily write that the answer is abducent nerve, because rest of the muscle nerves, they do not provide for the movement of the eyeball. Now, talking about question number 14, cranial nerve not carrying parasympathetic fibers is oculomotor nerve, facial nerve, vagus nerve, hypoglossal nerve. So, when you're talking about parasympathetic fibers, which functional column that it includes? That is general visceral efferent, right? So, what are the nuclei present in the brainstem for this? Remember, it was Edinger-Westphal nucleus. Then you have lacrimatory nucleus. Then you have superior salivatory nucleus. Then you have inferior salivatory nucleus, and then you have a long nucleus extending from open to the closed part of medulla. So this is the dorsal nucleus of vagus, right? So this entire functional column is called the general visceral efferent. From here, the preganglionic parasympathetic fibers will arise, right? So from Edinger-Westphal, this is the third cranial nerve which carries parasympathetic preganglionic fibers to the ciliary ganglion, and from ciliary ganglion, this is ciliary ganglion, and from ciliary ganglion they will be, it is being relayed here, then through the, remember, short, very important, short ciliary nerves, it will constrict the pupil. Then lacrimatory fibers and superior salivatory fibers, both of them, right, they will pass and will reach to two ganglion, the one ganglion and the other ganglion. This reaching to this ganglion, that is called pterygopalatine ganglion, and this is submandibular ganglion. So this bundle is being carried through, yes, greater petrosal nerve, and via to this, maxillary nerve, then zygomatico-temporal nerve, and then to the lacrimal nerve, will reach to innervate lacrimal gland, right? Not only lacrimal gland, but all the mucosal glands of the nose, pharynx, larynx, soft palate, like, um, all this region, that is muzzle area. And this ganglion, pterygopalatine ganglion, is also called, that's why, the ganglion of hay fever. And superior salivatory ganglion, from here there will be fibers reaching from then through this lingual nerve. Lingual nerve will reach to supply, branches will reach to supply the, yes, submandibular salivary gland and sublingual salivary glands, right? And this nerve is which nerve? Chorda tympani. Then there is nerve arising from here, preganglionic fibers arising from this inferior salivatory nucleus via this, glossopharyngeal nerve. This all, from lacrimatory superior salivatory nucleus, it was fibers running, sorry, these were fibers running into the seventh cranial nerve from lacrimatory and superior salivatory. Now from inferior salivatory nucleus, it will be through the ninth or the glossopharyngeal nerve. And through this, nerve to tympanic plexus, then lesser petrosal nerve, it will reach the otic ganglion. From otic ganglion via auriculotemporal, it will not reach the parotid gland. Parotid gland. And from dorsal nucleus of vagus, this will reach the viscera. Let's say a lot of viscera, bladder, rectum, uh, git, whatever, lot of viscera, all the viscera of thorax and abdomen, including the heart, they will reach there. And the ganglion for all this, including the heart, let's say the ganglion, actually these parasympathetic ganglion, they lie either close to or within the viscera it supplies. So that is through vagus nerve. So these are the four cranial nerves which carry parasympathetic outflow. Remember now: oculomotor, facial, glossopharyngeal, and vagus. Okay. So here your answer will be which nerve? Hypoglossal nerve. Not carrying fibers, they have asked. So answer will be hypoglossal nerve. Next question number 15 is: ear is protected from loud noise by vestibule, modulus, stapes, stapedius. So remember that stapedius is a muscle which dampens the oscillations of the stapes bone. So stapedius actually dampens the oscillations of these stapes vibrations, and therefore reducing the amplitude of the pitch of sound reaching to the internal ear. So it thereby protects the ear from loud noises. So stapedius, it actually, that is, stapedius is the word, better word, stapedius muscle, it causes dampening of vibrations. So it protects the ear from loud noises, right? And stapedius is being supplied by seventh cranial nerve, and it develops from second branchial arch. By the way, there is another muscle in this middle ear, and that muscle is called tensor tympani. Now, this tensor tympani is attached to malleus. Malleus, the handle of malleus. So, and tensor tympani develops, it is innervated by, this is the muscle derived for first branchial arch. So this is innervated by the mandibular division V3 cranial nerve. Okay, mandibular nerve, and it develops from the first branchial arch. Now what happens, remember, tensor tympani, it actually increases the vibrations of the tympanic membrane. Got it? So it increases the vibrations, stapedius decreases the vibrations. Now think about the, clinical point. So what happens if tensor tympani gets paralyzed? It will cause hypoacusis, right? And what happens is stapedius is paralyzed? This will cause hyperacusis. Right? So this is in short revision about the muscles in the middle ear, stapedius and tensor tympani. Now question number 16 says that the gland derived from the third pharyngeal pouch is anterior pituitary, posterior pituitary, thyroid gland, thymus gland. So remember, anterior pituitary develops from Rathke's pouch, that is from oral ectoderm, and posterior pituitary is an extension of hypothalamus, extension of hypothalamus. Thyroid develops from, thyroglossal duct, which originates to foramen cecum and all, and descends down and ultimately settles here in between. Then thymus is actually which develops from the third pharyngeal pouch. Third pharyngeal pouch. So the answer will be thymus. Now let's fast revise about endodermal pouches. So this, let's say, is the first endodermal pouch. Second is this. Third is this. Fourth is this. And fifth is probably this. So what are the structures derived from the first pouch? Remember, it will be the, yes, hold on. So first endodermal pouch, actually it gives a tubular extension which reaches towards the middle ear cavity. So it forms the auditory tube, which also is called eustachian tube. And remember, this is 36 millimeter in length in an adult. This also has been asked once. Then it will form the lining of the middle ear cavity, and that is called tympanic cavity lining. I think you should use the tympanic cavity, the lining of tympanic cavity, the middle ear cavity, and the lining of inner surface of tympanic membrane. So all this being derived from the first endodermal pouch. Now what the structures derived from the second pouch? This will be tonsil and the tonsillar fossa. Tonsillar fossa. Now talking about structures derived from third pouch. From the third pouch, it will be the thymus. You've just marked this as the correct answer. Thymus is one thing, as well as because thymus descends down. So along with this, there will be the, this third parathyroid. Or rather, in fact, I shouldn't say third because it's derived from the third, although this is called inferior. Why inferior? Because it descends along with the descent of thymus. That is the inferior parathyroid. Now fourth, what develops from the fourth will be superior parathyroid. Right, so it stays there where it is developing, but the third one actually crosses the fourth endodermal pouch and reaches down. So that's why third forms the inferior parathyroid and fourth forms the superior parathyroid. And that it is also said that this fourth endodermal pouch also gives rise to the swellings which forms the lateral part of thyroid gland. Right, and the fifth one actually gives rise to, this ultimo branchial body, which is supposed to give rise to C follicular cells of the thyroid. Okay, so that was written. Let's move further. Next question, number 17, is tapered inferior end of spinal cord is called conus medullaris, phylum terminale, chorda equina, ligamentum denticulatum. So spinal cord, just it is descending down and it tapers like this. At what vertebral level? At the lower border of L1. Then it is covered by pia mater. This pia mater tapers there, and it continues down at the tip of coccyx, right? And this is called phylum terminale, right? Then there is another layer surrounding, and this is called arachnoid matter. This arachnoid matter continues down up till which vertebral level? S2, right? And then outside to that there is dura matter that also descends down and reaches to which vertebral level? At the same S2. Got it? And you know that what lies in the subarachnoid space here, it will be CSF. So this is called the lumbar cistern of CSF, and that makes it a common site for lumbar puncture between L3 L4. Okay, lumbar puncture, common site. Then talking about the structures, the named here, this portion, this is spinal cord, and this portion is called conus medullaris. This is conus medullaris, which has been asked in the question. Tapered inferior end of the spinal cord is conus medullaris, right? Phylum terminale, I have also already mentioned, that is modification or an extension of this pia mater, and don't forget that phylum pia mater between each spinal segment also gives these lateral extensions, and these are called the ligamentum denticulatum. These are 21 pairs. The first pair is within this foramen magnum, attaches to the margins of foramen magnum, and the first pair, foramen magnum, and the last pair, where will be the last pair? The 21st pair, remember, it's between T12 and L1. T12 and L1. L1, less of space. Then what else can be covered here? Yes, there's spinal nerves. You know, all these spinal nerves, they arise from in between these, from each spinal segment, because each spinal nerve from, in the cervical spinal nerve, they arise from above the corresponding vertebral level. Then C8 spinal nerve arises between C7 and T1 vertebrae. Then thoracic, lumbar, sacral, because all these thoracics below T1 and onwards, all the spinal nerves will arise from below to their corresponding vertebral level. So that is how the spinal nerves will keep continuing descending down and will pass out from below to their corresponding vertebral level. That is the pattern. Now what you are finding inside, they are not the spinal nerves. Remember, these are the roots, spinal roots, because remember the two roots join to form a spinal nerve here, where actually this is the intervertebral foramen. These are important points. So these are the phylum termini. This is what you're seeing here. Within this is called cauda equina. Now cauda equina, don't confuse, this is not made up of spinal nerves. It is made up of nerve roots. This is made up of nerve roots, not by the spinal nerves, because these nerve roots will join at the intervertebral foramen to form a spinal nerve. Okay, so all the relevant important points I have covered here. Next question is, epidural space of vertebral canal contains. So in the above diagram, what I have already drawn, let's presume that this is the vertebral canal, like this is the vertebral canal, right? So what lies outside to this, this, the black color thing, this was, hold on. This is the vertebral canal, this is the dura mater. So between dura mater and the vertebral canal, the bony wall in the inner bony wall of the vertebral canal, so this is called epidural space. Now what lies, epidural space of the vertebral canal contains, they are asking like what lies here. So CSF, of course, I have told you that CSF lies in the lumbar system, that is the subarachnoid space, and the another space of CSF is this, that is within the spinal cord, and that is the central canal. Now this is the central canal of spinal cord. So you have CSF there. So these two options are already ruled out because you don't find CSF in epidural space. Now what you find is blood vessels and roots of spinal nerves, blood vessels and extensions of the dura mater. So remember that as I have already drawn in the above diagram, you will also find a plexus. This is a plexus, both the sides. This is internal vertebral venous plexus, internal vertebral venous plexus. And of course, you will find the radicals of the spinal artery also. The radicals of the spinal artery. So, spinal artery. That means you'll have blood vessels here in the epidural space. And extensions, blood vessels and roots of spinal nerve. You see the yellow color thing. I have already taught you that these roots of the spinal nerve, sorry, yellow color. Now look here, roots of the spinal nerve, they will continue down in the epidural space. Remember, cauda equina. And as I told you that the roots will join to form the spinal nerve. This is spinal nerve, and these are roots. Remember the ventral rami, not the rami, these are the roots. The ventral or the motor root, and the dorsal one is the sensory root. They join to form a spinal nerve. This is happening in the vertebral canal. So what you'll find in the epidural space, you will find the nerve roots. Okay, and then what remains is extensions from dura mater. I already told you it's the extensions from pia mater. So extensions from pia mater is actually the ligamentum ventriculatum and the phylum terminale, that also will be in epidural space, but that is an extension of pia mater, not of dura mater. So your answer to this question number 18 will be blood vessels and roots of spinal nerve. This is a good question. Question number 19. Question number 19 is part of the brain not involved in vision. So when you talk about vision, fast revision, retina is one thing which receives the light, then it's optic nerve, then it is optic chiasma, then it is optic tract. We are talking is about the conscious visual pathway. Then optic tract, actually, optic tract, 90% fibers reach into LGB, right, which is a part of thalamus, and 10% fibers reach into the midbrain. Midbrain, what part? Tectum, superior colliculus. Okay, then from LGB there is optic radiation that reaches into this, this calcarine sulcus, right? So this calcarine sulcus is where, actually I should have drawn it in a better way, then you will understand it better, that you talking is about this, this portion of this cerebral hemisphere. So here posteriorly you find is the calcarine sulcus on the medial surface, and here you have is this, the corpus callosum. So this is optic radiation, and then it is the calcarine sulcus, or area number 17, you know that. And this is actually occipital lobe, or you can say is occipital lobe. So, part not involving brain, here I have shown you the temporal lobe. I haven't shown you anywhere here. Occipital lobe, of course, is a part of this visual system. Tectum of the midbrain for subconscious visual reflexes. Remember the constriction of the convergence of pupils, constriction of pupils. You need this. Then you have this. Convergence of the eyes, like remember, nucleus of Pearly and everything, or there are lectures already uploaded. Go into the playlist of ophthalmic anatomy, you'll find a lot good many lectures on this portion. Then tectum of midbrain has been done. Lateral geniculate body I've already mentioned. So your answer will become here is temporal lobe. Okay, lastly, in the same slide, I'm showing you is most important autonomic control center in CNS is autonomic control center, central cerebral cortex, sympathetic chain ganglion, thalamus, hypothalamus. So remember, I'm showing you here is this is the brain, and here somewhere you find is the hypothalamus, and from this is the midbrain, pons, medulla, and then this is the spinal cord, right? And in the spinal cord, you know these are supranuclear fibers coming from hypothalamus. Where do they reach down? Into the lateral horn. Lateral horn from T1 to L2 for sympathetic outflow. Then from there, the preganglionic fibers will relay in the sympathetic ganglion, and postganglionic fibers either will ascend or will pass out or will descend into the sympathetic chain, right? So this is how what is happening. In case of sympathetic pathway, parasympathetic also, remember the supranuclear fibers, they are pre and post ganglionic fibers in sympathetic and post sympathetic both. But this, pre-ganglionic fibers, before to that, there is the supranuclear fibers. They are all coming from hypothalamus. So remember that hypothalamus is the chief regulatory center for all autonomic important activities. So most important autonomic control in CNS is hypothalamus. I believe you got the answer for all of them. You understood. Keep a revision of this. I'll be posting more. The second paper also very soon. Okay.